whole world is changing around us. There are the payers, the new companies that are starting up, and we're just trying to figure out how all this comes together and how it's going to change our lives. So I thought that I'd start out by asking you guys the questions. I mean, what are you doing to healthcare? Bruce, you now have started out with a relationship with Walgreens. You've started out with Kindred, and you now have a studio in Boston, Studio H. Why is that not in Cleveland?
Well, we wanted to put it in Cleveland, but the weather just wasn't as good there.
Oh yeah, it's nice weather in Boston.
Yeah, that's it.
You need to move it to San Diego, of course. We all know
after
the
today,
weather
it would be
Yeah.
great.
So anyhow, tell us, why all this going on around payers?
One of the things that's happening in healthcare is the definition of success is being changed. Is being changed to helping people live their life through a much better health. And so when we see that changing, we also see the enablers of that change to be including technology, we find these interventions where have the most impact on health. Primary care is one of them. Home is another. Behavioral health, social determinants, and pharmacy. And so our organization is really oriented to how do we take risk, full risk, payment for managing a population, find these interventions through partnerships and own models, and integrate it through technology. All wrapped around how do we improve individuals' health. Before it was about maximizing a transaction, about maximizing utilization or minimizing utilization, and now it's really changing to much more about how do we improve people's health.
For me, being a tech guy, I see tech and healthcare often dehumanizing the situation. So I got involved with this company called Heal, which does house calls, 100,000 house calls already. And it's kind of like the Uber model where you use the software to get the doctor to the right place at the right time, do all the logistical stuff, take away all that administrative work away from the doctor. And now the doctors actually get to go into the person's house, see how they're living, see what pills they're taking, are they smoking, or did they call us for a cold and we actually find out that there's something worse going on. And so it really transforms by going back to the future, the entry into the healthcare system, and it uses technology to rehumanize healthcare, and that was a thing that I got very excited about. And I had liked this idea for many years. I had a friend that was a COO of an ambulance company way back when, and we had this idea of doing house calls back then, but back then the equipment was all so cumbersome. It was basically we outfitted something a lot like an ambulance with a lot of equipment, and it wasn't economical. And that sort of started this journey at Qualcomm to try and make the medical equipment more capable but light and mobile. And that sort of led into some stuff that now we're actually using at Heal. And I'm happy to say after this very long journey, we actually got Medicare reimbursement for an IoT device that got plugged into a patient's home and is monitoring their chronic conditions. And so a Heal doctor can actually see when something's going wrong and come to the person's house and take care of them.
Let's as these changes happen, and you go back, what's going to drive these faster? And we're talking now about going from volume to value. Mm-hmm. And we've been at this now 10 years. We've been talking about this, and how we're just barely getting there. Yeah. And all of you making your bet on going there. What's going to make us actually get to the value equations for healthcare?
A few things there. I think there is a little bit of boiling water happening that the water is getting a little hotter. And what I mean by that is that when I think about Medicare Advantage, which obviously, that's you. That's us. I mean, it defines us. It's what our brand's about. It's gone from about 10% of the Medicare population to 35%.
Right.
And that's a wonderful example of payment for value and for payment for value around cost and quality. Full risk taking, population health. It's not an insurance product. It's much wrapped around that. I was had a breakfast with a chief medical officer of a large health system just a few weeks ago, and he mentioned to me that they earned about $150 million last year. about 100 million was from value-based payment models. We're seeing it in some of the providers that we deal with, that the value-based payments are becoming more and more part of their profitability as a percentage in total. And so we're seeing it happening and starting to penetrate. And a few things that I believe that will accelerate it, getting back to that. More payment models, so not just like Medicare Advantage, but more payment models.
Now, is that the private sector as well?
I think government has to lead this more than the private sector. I think it's a little harder in commercial. Choice is a bigger issue, a bigger need there than I would say the payment model, and it's more episodic than chronic. And I think the chronic conditions really lend to a much bigger population health. You can do bundled payments, but I think the chronic side is much more oriented to population health. The second thing I believe is interoperability. There's a lot of talk around data flow and data integration, but interoperability makes it much easier to manage upstream and downstream. Quality measurements are the third that I think are really important to that. And the last one, I know you want to ask another question, is social determinants. Paying for not just the healthcare costs, but also some lifestyle costs that include the benefit from a healthcare point of view.
One of the things that we see is just keeping people out of things like the emergency room and urgent care. Clearly, you're going to get great outcomes having the doctor go to your house and see how you live, but you're going to save a heck of a lot of money keeping people out of those kinds of institutions and facilities. So I think and we've actually structured our deals in many cases around the cost-saving aspect. So it's not just capitated, but then there's also a cost-saving aspect, which is super important.
So how many employees did you have previously in your previous company?
Depends when, but in the 30 plus 35,000.
And why did you push towards wellness and trying to reduce the costs in that group?
Yeah,
and did it pay off?
I think it was too short of a time for me to tell you whether it paid off or not. But we absolutely did those programs. I ended up moving on from my position, so I wouldn't say that I saw it. But for sure, we were focused on it, and it certainly paid off from some of the cost standpoints, because the way that we were compensating the employees and so forth.
Yeah, you know, it's really interesting because 150 million people in the United States have private insurance and work for some sort of a company. And I always thought that private companies were much more nimble than the federal government would be. And I've been
You haven't dealt with an HR department.
I'm sorry?
You haven't dealt with an HR department. No, actually, you must have, so you know.
Yeah. Well, I dealt with the HR department. I dealt with the HR department when I stopped hiring smokers. I had to get a new head of HR in order to do that. So back to the technology aspect of things. So where does that fit into getting to value for you?
A few things. I think first, there's been a lot of talk today about AI and whether cleansing data to the ability to take data and create interventions and be more proactive. What we see in the ability to use technology is first be able to identify when someone is in need. One is someone in need of an intervention, whether it's a prevention intervention or there's a prediction of a heart attack or someone's not following their medications. And then the next is what is that intervention? Is it a home health nurse going into the home or a doctor? Is it someone having an outbound call? Is it something that needs to go to get them to an institutional hospital or something like that? The second area that we see technology being really important is the growth in devices. The ability to use devices to monitor individuals in their day-to-day life and be able to then take that intervention and or that data and bring it back. And then the third we see is the ability to share data amongst the healthcare system, to be able to use that data so that people that are surrounding the individual's care model understands what interventions are there and understands basically what needs to happen and who has also been part of that, to have a sort of a 360 of the individual.
So Paul, what's 5G going to do for healthcare?
I mean, wireless technology in general is going to give you the opportunity to be more connected so that we can take these, sensors and communicating devices and computing devices that have been cost reduced by being sold in the billions and apply them to other things. And that's the IoT, Internet of Things, and we had coined the term the Internet of Medical Things. So 5G, there's a lot of hype around ultra reliability and having low latency, meaning, I send something, it doesn't take very long for it to traverse the link. And actually at my new company, we're very focused on use cases for that. And we were just having a discussion this afternoon about whether you could use virtual reality for Parkinson's, for understanding some of the issues that come about with Parkinson's patients. And I don't know whether that's going to work out, but this is the kind of thing where I can give you an environment and you actually can go around and you see certain things, but you're free to walk around with it because we've made the headset super light. You're not carrying around all the rendering with you. It's sort of 5G plus the idea that you're going to have the computing done in the edge of the network, not right on the device that you're carrying around with you. So that kind of stuff will be, I think, really transformative to all of our lives. Eventually, of course, it's science fiction to people today that you just put on glasses and see this, but it's definitely coming.
So where's telehealth fit into your model for HEAL?
Telehealth is one aspect of it, but it's really like the follow-up. And for us, right now, we really are about getting the doctor to the house so that they see all of these things that Bruce was just talking about, all the social determinants and just everything about how the person's living, this sort of more holistic way of seeing the patient.
How about you, Bruce?
So telehealth for us has a multitude of different touch points. First, it's around how do you get specialists to rural markets there.
Yes.
I think that's an important area where you can get care that once wasn't delivered in the smaller parts of the country. The second part is the ability for us to, you mentioned about our acquisition of Kindred. One of the reasons why we acquired Kindred is there's about 80,000 nurses in this nurse distribution channel that we can complement a telehealth visit with a nurse going into the home, that it can be assisted telehealth, that you can get you can do diagnostics, you can write a prescription, you can do all the things that you would do in a physical office in the home. And that really begins, especially in under-resourced areas, begins to extend the healthcare system to a much broader area. And so when we think about population health, and we think about prevention, and we think about all of the things that we're looking to try to get in front of, proactive care, telehealth is at the center of it because it is much more powerful and much more distributed in the way it can.
But so we had an experience, though, that just a cautionary tale, where we had a patient that was using purely telehealth, and they had a migraine, and they were calling to get diagnosed and prescriptions, and went for a while and didn't work, called HEAL. The doctor came to the house, saw there was black mold in the bathroom, cleaned that off, and the migraines went away. So, I mean, I think it's a mix of the two, and we, for sure, when the doctor's driving around in the car, going from one place to another, by the way, somebody else is driving, they'll be able to use telehealth to do follow-ups and other kinds of care. So I think it is important, but we feel strongly that this mixture of the personal touch, the actual human touch, is still critically important.
That's important. I just emphasize that's why we have nurses going in there to we call it assisted telehealth, as opposed to take FaceTime and just put your face in front of an iPad.
So I'm going to open it up to questions here in just a second, but I got one more question that I'm going to put them on the spot for.
Not your payment.
Wait,
we're not going to raise your rates.
No, you're not?
No, sorry.
Oh, damn. Oh, so then I'm going to be really ugly with you.
Okay.
Okay, so what happens to Medicare for all?
Okay.
Are we going to have Medicare for all?
So
let me give you a choice. Medicare for all, improvements, or the ACA goes away.
Oh, I can't have A, B, or C. Let me customize it.
Okay.
Can I do that? When you think about healthcare, there's really three different channels in healthcare. One is who pays for it, who coordinates it, and then who provides it. I think the government will always be in the payment side. I don't know if they'll be in the coordination side and the provider side.
Well, now wait a minute. They have the thing called the VA.
Yeah, but
which is a nice little 2 million patient experiment.
Yeah, but I don't see them expanding that. In fact, I see them shrinking it because they're starting to outsource a lot of that to the private sector. I just am a big believer, and this could be my bias here, that there is a need for a private governmental partnership, and no different than what they're doing in space today, or what they do in military today in making equipment, is that that the innovation and the ability to bring really good capabilities to the healthcare system is required with the private sector. I do see, and you asked me about all the things that are going on in the payer world and the provider world, I do see the coordination of care and the provider of care being intertwined. And that gets back to the payment model. As you begin to change the payment model to outcome-based, coordination of care becomes much more important.
So this, let me ask you,
Push to
are you going to buy the Cleveland Clinic, or are we going to start an insurance company?
I don't know what you're going to do, but I know I won't buy the Cleveland Clinic.
Well, you know, it's one time only, good chance.
No, I think, you know, Humana was in the hospital business for a long time. And we sold our hospitals in 93, and we found that it was much more effective for us to be in the coordination.
Well, that's not such a silly question, because Optum has now got 40,000 doctors.
They do. And we have 300 clinics. And I do believe, as I was saying, there's an intersection between the coordination of care and the provider side. What I would say, and I know from our point of view, it is really market dependent.
Okay.
If there's not a provider in the marketplace that's sophisticated and taking risk and not wanting to take risks, then we will bring capacity to the marketplace.
Okay, Paul, you don't get off easy on this one.
Well, I was going to say my wife's Canadian, so I have a lot of experience with the Canadian healthcare system, which is sometimes, you know, held up as this great system, but I've seen its failings as well. The thing that's interesting is there are great doctors in Canada. No question there are great doctors.
Absolutely no question.
But the way that you get to see them, the best ones, is by who you know. So there's still a currency. It's just not money. It's like, do you have the connection to a friend of a friend who gets you in? And that's, you know, that's how the system actually has worked. And it's, you know, I don't think that's exactly what we want. The other thing I would say is I have a friend who runs insurance up in Canada, and they sell an insurance to Canadian citizens that if they have certain things, they can come to the United States to get their care. So not that our system is so much better necessarily or worse, and it's very different, and I do think there's, you know, this issue of your currency. Like, how do you get into, you disagree?
Okay, we're going to open it up here. There's a panel back here, there's a question in the back.
Hi, Greg Simon, Biden Cancer Initiative. I have a question about cancer. What's the rationale for charging patients copays when they only have one choice for one drug, as compared to blockbuster days when you're trying to get them not to buy Viagra, Botox, or a brand name when there's a generic? Cancer is very different. Nobody's making a living off patients' copays, so why do we have it?
It's a good question. I mean, there's a design principle in plans about tiers, and that's one of the questions you're asking about. And in general, what copays try to do is to ensure the most effective decision making. I agree with single source and what you're getting to. But when we begin to start taking one drug off the copay that has certain characteristics and substituting for another, it becomes much more difficult. What we do for our members is we begin to look at sponsorship for dollars to help with the copays, and being able to subsidize the copays for people that can't afford them to be able to help with the care. And that, to me, is the most important thing, is ensuring that people get the care, but do it in a way that is still in the construct of designing a product that is most cost-effective.
Okay, we got one question over here, and then time for one last one over here.
Hi, my name is Luana Ojala. I'm the CEO of Caring Bridge, which is a nonprofit focused on health journeys, and we've been a social network for 22 years. And my question is, what do you see in the area of technology to support caregivers and harness the power of social support for patients?
I'll take that on. A few things there on the caregiver side is having a holistic view of what's going on with the individual is an important part of that. So first is just what's going on in their life, contextualization of what's there, including are they taking their medicine, or what medicine are they on, those activities. The second part is especially distant caregivers. We have a company called Senior Bridge that actually helps take care of individuals on behalf of caregivers. And what we find is the distance away from people is also a challenge. So community services that can help them, whether it's helping them, with the roof leak or being able to help them with loneliness and other things like that. And so it's the ability to see what's going on in their life contextually and then being able to help them on the day-to-day life's challenges that they have.
Okay, then the last question over here.
Hi there, Steve Papermaster. Question is on public-private partnerships. If we think of a model where NASA is working with SpaceX and a few other private providers, what is the equivalent of that we could postulate in health?
Yep. Again, I'm going to be biased. But I think Medicare Advantage is a wonderful payment model where it encourages public partnership and holds the private industry held accountable for cost and quality around paying a fixed fee, responsible for taking care of the complete holistic aspect of the member, a patient for that matter, and doing it for a long period of time. A individual decides to come to us, we're not an HR department, not a government. They decide if they want a Humana or a United or whoever it may be, and so they're empowered for it. And in addition, what it does is it focuses on more holistic payment. We build, a ramp in someone's house if they just had a hip replacement. We'll put a shower bar in the shower, making sure that they don't fall. We'll give them food, and when they're discharged from a hospital, to ensure, knowing that their refrigerator will be empty or the food will be bad during that period of time. And it really forces a complete holistic view of it. And so, to me, bias, Medicare Advantage would be a great example of that.
Well, good. I want to thank you guys very much and thanks for the great questions.
All right. Thank you.